So I'll start. I'm Professor Ian Hickie, the Co-Director of Health and Policy at the Brain and Mind Centre of the University of Sydney. And thank you for taking the time this evening to join us as part of our Flip the Clinic series from the Brain and Mind Centre on, I've got to say, one of my favourite based topics. And I think I've got at least 3 friends who are similarly interested in the topic of measurement-based care in a digital age. And I've collected at least 3 other people who are here this evening to have that discussion with us. I'd like to start by recognising the traditional owners of the lands on which we meet. For those of us here in Sydney, the Gadigal people of the Eora Nation, and the wisdom that they have brought to this country over many, 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 many decades of experience and of wisdom and of teaching and of learning. Also to recognise those with lived experience of mental health and suicidal ideation and those lives who have been directly impacted by the issues that we're going on to discuss. Often I walk around in clinical settings and people go, measurement-based care, what the hell are you talking about? What is that? What is the meaning of that? And certainly in some of the co-panelists tonight, when I was discussing them, does anyone know of measurement-based care being used, in fact, in any of their services? We're all scratching our heads a bit to try and find good examples. The concept is an important one and one that we've tried to take forward recently in our work. If we go to the next slide, in particular, 2 aspects of how do you not actually just do better assessments in our area, in the blue part of that circle on the side of the screen. But, you know, really the issue is as time goes forward, do we have real-time monitoring, which at the individual level, we actually track whether you get better and you actually adjust treatments in real time in relation to people's experiences of care. As I say all the time in the systems in which I'm working, I don't really care so much for those who get better, but I really care about those who get worse or don't improve in the systems of care we have. And do we even count those experiences in a healthcare system that is totally preoccupied with activity, not outcomes? Over on the left of the screen, you'll see a particular book I just want to highlight, which was a book that was written prior to the Obama reforms in the United States. What's the right time for healthcare reform? Now. We are sitting in one of the largest mental health crises that most of us will see in our lifetime as a consequence of the COVID-19 impacts on our society, on our healthcare systems, on our economic and educational contexts. At the same time, we have a Productivity Commission report sitting with the Treasurer. We have a Royal Commission running in Victoria on the top of many, many actual previous discussions. In that discussion, I'd like to suggest that the right time to do something is now. As part of that now, accurate collection of data at the individual level, which can be aggregated up to actually give a better understanding of who is responding to care and how that is happening, and a care system that is fundamentally responsive to individual need might actually be prioritised. As my great friend and colleague Alan Fells points out, most people from healthcare and healthcare planning go in the opposite direction. They're top down. They're basically old Stalinists who say, we know what is best for you in advance and will plan the system for you. And that system is relatively unresponsive then to what actually happens to you on an ongoing basis. And I'd like to suggest that now's the time that we really need to think about that quite differently in the 21st century, since we have technologies that might assist us. Can I go to the next slide? Mental health is complicated. And what we measure as outcomes when we talk about measurement-based care really does matter. And in the work we're associated with, for those who are interested, we've described this in detail in the Medical Journal of Australia last year in youth mental health. There is more than one outcome. There are key areas in terms of social and occupational functioning, participation, there are illness factors, there's suicidality, there's physical health, and there are other comorbidities. But we have the capacity to measure more than one thing. I'd like to suggest we can do more than walk and chew gum. And we don't have to have necessarily simple sets, often what is measured in clinical trials as being just one outcome. People's lives are more complicated, and we need to consider what from a person perspective is important in terms of an outcome, what we are measuring, but we do need to define it, and we need to look at the extent to which our interventions and people's experiences are relevant. Okay, that's my basic diatribe as to why I'm so interested in a different kind of system. Joining me tonight a range of panelists who share, to some degree, interesting sets of issues. But just before we start, really important to get the perspective of a young person who's in the middle of such systems. And Sam Hickie, who's been a great attribute, a great colleague for us at the Brain and Mind Centre and my own work previously in the National Mental Health Commission, we thought we should give him the first word as someone with lived experience. So if you could run the video, thanks.
Thanks so much, Ian, for this opportunity to talk about my own mental health, my journey, and the way in which measurement-based care has actually impacted that journey. For me and my psychiatrist, management of my mental health and the fact that I fall upon the sort of circadian bipolar spectrum means that measurement and being able to track my sleep, being able to track my exercise, my diet from a nutritional point of view, also my blood levels as well, from iron, from glucose, from testosterone, all of those sorts of pharmacological side of things is a major key to being able to aptly and appropriately and react effectively to my mental health and managing my mental health. For me, like I said, it's been a major game changer. Being able to, I guess, being empowered to be able to identify the changes, so that when I'm actually thinking, am I in another depressed rut, or am I about to enter another depressed rut, I'm able to then actually look within myself and sort of think, okay, well, what are the actual things that I've been doing? Have I been getting enough sleep at night? Have I been getting good sleep at night? How's my routine going with that? How is when I'm awake, how are my activities? Am I getting enough exercise during the day? Am I getting exercise at all during the day? Or am I getting too much exercise? And at what times as well? And then from a diet's perspective, it's like, am I putting the appropriate foods into my system that are going to allow me to reap the benefits of that? So for me, I occasionally have an iron deficiency, and so being able to understand that perhaps I'm not entering an episode of depression, or more severe depression. I'm actually just going through a lack of iron within my system, and so that could mean upping my diet. That could mean going on supplements. Could mean a whole sort of thing, a bunch of things. But I wouldn't know that if I weren't empowered and equipped with the ability to go through the tracking, to have those blood screens, to know the signs, to be able to work out how to then intervene appropriately, and it not be just a whole bunch of guessing games. So I think for anyone considering using measurement-based care within their patients or their people, sorry about my clock, it is something that really is beneficial, and I find it personally, I find it incredibly empowering to be able to react appropriately, to be able to understand what's actually going on from a medical perspective in my system, and to be able to then beautifully line up and appropriately line up my emotional and mental side to my physical and biochemical side.
Sam is such a great contributor to our work, and I hope you caught those words about empowered and tracking me and my biology and his clock, which I love, because he has a clock that goes off, and we have a lot of discussion about his body clock and a shared perspective between himself, his treating agency, and that his actual complex set of experiences is being mapped in relation to his own particular illness and its course. So joining me for the rest of this evening is this illustrious panel here, clearly more attractive necessarily on the right than the left, but a wise group of people who actually will make various contributions, who are interested in these particular areas. So at this point, I'm going to pass right over initially to Dr. Danny Rock from the Western Australian Primary Health Network, who has a long and considered engagement with Danny. Is it ready for prime time in mental health?
Oh, It's always prime time in mental health, Ian. Thank you. I noticed I was on the extreme left of the distribution of physical attributes. I noticed in the picture, and I should point out that the photograph is quite nice because it was 5 or 6 years ago when that was taken, and I looked a rather happy soul. What I'd like to talk about is, what I'll get to is to talk about optimization, but I thought it was important in doing that, to locate on the territory where we operate, because it's very easy to, in this whole issue about healthcare, to overstate and to conflate where the work occurs. So, and this model is a model that I became familiar with when I was for a brief time working in Stanford in the US, and it's in the Bay Area, and it nicely positions where we're at. So on the left side of the model is all the causes, all the things we know that are associated with the cause of illness. They're the things that cause the incidence of cases. And we in the treatment system act very little on those. We have to know them, but we act very little on them, because we're principally focused in the caseness business. So that people coming to us, and I've said it, and it sounds a bit pejorative, but it's true. We're sitting somewhere between risk behaviors and death, and that's where we locate treatments. We have to try to push back the other way to the extent we can, but recognizing we're in the caseness, not the causeness business. I think that's the first container we have to think about when we're thinking about optimization. Can you go to the next slide, please? And looking at where the system is, I think the Productivity Commission report it's an interesting report. I don't think it's as damning as people. I don't think it's as damning as sometimes described. But one of the things that struck me when reading it was their concern, not particularly that things have got low or zero value. I mean, that's kind of self-evident, but that much of what we're doing has indeterminate value. It could be good or it could not be, and we simply don't know. And we ought to, because we can't improve care if we don't know the value we're generating. Can you go to the next slide, please? And the good thing it does focus on value. It's saying, what is the value we generate, and a simple or the straightforward way of thinking of value is a concatenation of 3 things. It's personal value, of course, people, their experience of care, and the technical value and the allocative value, and they can't be decomposed to the point that they are orthogonal from each other. They are dependent in a way. But I would argue and contend, well, I would contend, and others would contend, Berwick and other people more kind of learned than myself and Porter, that the personal value is the North Star in our system, and we assemble the system upwards from personal value, not down from allocative or technical value. And I can give you reasons why that is the case. Very simple reasons. You can't determine the allocative value if you don't know what the personal value is. You can't determine the technical value if you don't know what the personal value is. Can you go to the next slide, please? And that gets us to something that's a simple slide that's often misunderstood. And this is an old slide, not an old idea developed by Donabedian. Is that, well, if you take a population and you do an RCT and you have a treatment. Just a second, I just want to stop my system rebooting here. If you do an RCT and you implement that at a population level, a large number of the people who benefit the most will benefit the most and get early treatment. And progressively, as you roll the treatment out against the population, the fit starts to fall away, and the harms accrue faster, greater than the benefit. And there's a nice sweet spot somewhere in the middle called the optimality point or the optimality region, where you're not underdosing or you're not overdosing. And it's kind of neat from a population level. And that's kind of the way British Leyland builds its cars. If you want a Land Rover, they build it on the basis of some sort of, we're going to build a standard model and we're going to roll it out, and it's going to be pretty good if that's the standard model. But that's the model you're going to get of the range. However, I would contend you can apply the same framework now to personalized medicine. You can say an individual, and I think that the video previously was talking about this. We've got the opportunity using measurement-based care and digital medicine to personalize care, for individuals to have their own personal optimization point for their care, where they can make judgments about the harm and the benefits they wish from the treatments, and get the dose of treatment that they need, no more to overdose and no less to underdose. And simply giving people an RCT level of dose is insufficient these days. It's not good practice. It's not good practice in medicine. And it's the way Toyota builds their cars. They'll build a car for you. They're not building cars and you've got to choose from what's the thing. And I think that's the essence of measurement-based care at a personal level. And effectively, that is also results-based management. And Ian was saying, thinking of where is it medicine that this occurs. In psychiatry, I was struck that it occurs when we're giving ECT, and I'm a little bit of research when I was looking at ECT, and it struck me the difference between the way the anaesthetists approach the use of propofol and the psychiatrists approach the use of electricity, and how seemingly more careful it seemed to me, at least, that the anaesthetists were about their propofol dosing, whereas we didn't know enough about the dosing of electricity for ECT. And it's not saying it was wrong, we just didn't know sufficiently enough. The feedback mechanisms were not there. GPs, of course, work within a results-based management framework in everywhere but mental health. Next slide, please. And optimality sits within these pillars, which is older people like me would know about Donabedian. And we have these 7 pillars of quality and value. Optimality is one of those. It's obvious. We want to have the most advantageous balance of costs and benefits at a personal level. It's one of the pillars, and I was mentioning in the pre-meeting, whilst the Donabedian doesn't place an order on a rank order on these elements, these pillars, I think we do naturally anyway. We start from efficacy and we go to effectiveness. We work our way up, and we kind of stop somewhere near optimality. We don't quite get there, mostly, partly because we haven't got the technology. And it would be an interesting question to ask, what if we started from equity and work backwards? Would we get to the same sort of services, and would we maybe get to optimality a bit better that way? I don't know the answer. It's just an interesting, intriguing question. Can you go to the next slide, please? So what is missing? Well, I'm not an old Stalinist, and I do see the value of frameworks for containment. And I think at the top level, at the meso level in the system, we do have things that can have expertise embedded. We have the National Mental Health Planning Framework, and it comes in for a lot of criticism. I think much of it is misdirected. It is the synthesis of an enormous amount of expertise, and it actually provides at least some buckets, at least some broad scale things where you might start the dosing or the way you might think about care. But it can't do it at the personal level. It was never designed to do that. And what we have missing, if you look at the bottom, is, well, I can look up. I think I pull this out. So this is propofol. So this is the effective dose response curve of propofol. We know what, which is the anesthetic agents in ECT. So we know what the effective dose is for people, and we know the dose that poisons people. And when I look through the sorts of treatments that we offer, the psychological therapies, I don't think we've actually got any idea of we have a treatment that is beneficial, but you can't overdose on it, which seems remarkably odd to me, that we have there's no maximum dose. There is no actual, you can't calculate an LD50 for CBT. We have a notion of a dose response curve, and I think there's a missing bit there. And the missing bit there, I think, is we haven't got the capacity, we haven't got the capability to capture the data, though we should. Can you go to the next slide, please? I missed this one over. It's just, go to the next slide. So I would say in my key messages, the preference and needs of patients is the North Star, and value is not determined by people like myself who are funders. I think personalised care is systematically unachievable without the incorporation of measurement. And the measurement is a process, not an event. It needs real world feedback to achieve value and quality at all levels. So connecting up. Authority devolves, Ian hinted at this, if authority devolves up, not down, it goes from the nano to the macro. expertise of all forms should be built into decision making. There's no one best practice model. We need to focus on economies of flow as people move through the system and not just scale. And you can't do that without measurement-based care. And why we haven't done it, because whilst digital healthcare provides the most realistic hope for personalised care and mental health, it requires not investment into hobby projects of enthusiasts, but systematic investment into the basic building blocks of how we assemble care in Australia. And if we can do that, we can create truly personalised care. I think.
Thank you, Danny. Just as we go along the way, remind people and participants, there is a Q&A function on the bottom right of these webinars. And if you want to put in questions along the way and make requests, there was a request about providing slides, and we'll certainly try and provide slides along the way and to participants if they're interested. We certainly record these sessions and take them forward. I think, Danny, you've done a great job. The key messages there, I think we should just repeat over and over again in one way or another. And I really like the way you've actually emphasised the North Star kind of aspect. There's a lot of discussion for those of us who are in planning or clinical provision whether actually the preferences and needs of patients are the ultimate value. I think what we're also trying to do is aggregate that value up, know the number of people where that's been achieved in ways rather than averages, or as you pointed out, rather what trials might tell us about relative efficacy. They don't tell us actually about the optimisation of care. So I think there's some really critical insights in that presentation. Now, it's my great pleasure to move on to my old friend and colleague, Sebastian Rosenberg, who many people believe is a clinician and must have been a psychiatrist at some stage, but actually he's not. He's a PhD in public policy, actually, and has done his PhD with us on the issue of accountability within the system. That for the amount of time and effort and money and the extent to which we say we are accountable, not just to funders, but to the population we've worked with, this has occupied Sebastian for most of the last decade. So, Sebastian, are we headed down that road? Are we going to be accountable at the individual level or at the aggregated level?
Thanks, Ian. It's a pleasure to be here. So I think Danny set out the issues in a very interesting way. And before we get to too many discussions about throwing ourselves to be chipped like pets for personalised management and measurement, I think we need to recognise that issues like person-centred care have been colonised in mental health policies over the last 20 years. So I guess I just wanted to put my presentation today into the idea of measurement-based care into a broader national system context and to see how wet the ground is for this kind of innovation. Others will talk about technology and systems and so on. But the bottom line is we need to make a practical decisions about how we move forward with accountability. And I can see why we want to change systems, and that's because there isn't much of a system in play now. And I guess it's worth just thinking at the highest level about what is accountability, and I think there are two key issues here that are worth us bearing in mind. The first one is, I suppose, the close association between accountability and blame. And Christopher Hood put this in the Oxford Handbook of Public Accountability. Accountability and blame avoidance have much in common and can be understood as mirror image concepts. I find that to be fairly disillusioning because what I'm really interested in, I suppose, is the idea that measurement-based care can contribute to accountability for the purpose of systemic quality improvement. And here you turn to the other aspect, if you like, of defining accountability, such as was put forward by the Institute of Medicine, that across the healthcare system, accurate measurement and frequent, transparent reporting of patient experiences has the capacity to reduce variations in care and increase effective service provision. So I think, if you like, this is a duality that we need to struggle with. We need to make it as easy as possible and as acceptable as possible for everybody to participate in transparent, helpful processes of accountability. Next slide, please. And look, when I say everybody, I think it is worth dwelling on the fact that across our wondrous mental health sector, there are different people who have different perspectives. So a consumer's view about accountability might say, I'm just sort of suggesting here some questions, you'll have your own. But a consumer with a view to a system accountability might ask a question about a service like, will it work? They might ask how much it'll cost. They'd probably be interested in side effects. A carer might ask a question like, is it safe? The community might ask a question of a system about, is it reliable? You know, do they have trust or faith in their mental health system that it'll be there when they need it? A provider might say, well, I've been working this way for some time with what I can see as some sort of results for my clients, but how can I improve my work? What is it I need to do to be better at providing the care and the service that I do? Funders, of course, are critical, and they'd be asking questions like, is it value for money? And they may well ask a range of other questions as well, but we all know that that's a significant issue, looking for waste, looking for opportunities for cost efficiencies and savings. Evaluator, of course, might say, well, actually, you've done all this stuff, but actually, has it made a lick of difference? Has it worked? Has it improved the quality of life? Has it met what it set out to do? A policymaker, in a broader sense, might say, well, has a program or a service or a treatment achieved its stated goal? You know, are there better ways of doing this? And a researcher would say, well, you know, is practice really reflecting research findings? So, you know, is evidence being brought to bear? For example, the evidence that I might bring together as a researcher in the way work is done. So there are these different perspectives, and again, we need to be mindful of juggling. That said, I think it makes a lot of sense to start from the bottom and to start from the point of view of the consumer. When I say the bottom, I mean the focus. And so this measurement and personalised approaches to the collection and reporting of information makes a great deal of sense. The next slide, please. So here's proof that we've been talking about this since 1992. That is the first national mental health policy. And this is what it said, that there needs to be greater accountability and visibility in reporting progress in implementing the new national approach to mental health services. Currently, mental health data collection is inconsistent and would not be adequate to enable an assessment to be made of the relative state of development of the Commonwealth and each of the jurisdictions in achieving the objectives outlined in the policy. So they recommended two things: nationally agreed outcome measures and annual public reporting. And I guess really I could take you through the subsequent, well, what are we up to now? 5 national mental health plans. They stopped evaluating them after 3, but the third plan said they hadn't got very far with regards to these 2 objectives. The next slide, please. And this is what the Productivity Commission said only last year, that there was a lack of clarity about government roles and responsibilities, which led to persistent wasteful overlaps, yawning gaps with limited accountability for mental health outcomes. They also said, and you do have to go to volume 2, page 1011, and I really do need to get a hobby. The whole of government approach to monitoring and reporting on mental health outcomes has not been achieved in practice. This is a significant shortcoming given the significance of social determinants and impacts of mental ill health on human functioning. And this, again, leads me to say that, you know, we're not focusing on social determinants. At best, we're looking at health markers. And the third thing it said was accountability for outcomes and the creation of a learning system can only be achieved through a comprehensive and nationally consistent monitoring and reporting framework. So, 2019, I think we're basically saying the same thing we said in 1992-93. Next slide, please. So here's my summary. I would suggest generally we are not measuring. So whether it's a system or a person or an outcome, we're not measuring. And as an example, there have been only 2 surveys of mental health and wellbeing. So we're not measuring. The second thing is we're not measuring the right things. So I would say we are strongest in the health administrative data sets, which yield information like occasions of service. What we don't collect is the information which informs us about mental wealth. And here you talk about the outcomes which are often described as most critical to consumers and carers: homelessness, housing, employment, education, and so on, social connectedness. We're also not measuring the right way. We are putting impost on providers to collect information when there are technological options which we should be pursuing. An old parable is that what gets measured gets done. And the way this manifests is that if we focus on measuring beds or waiting times, then that leads to where investments get made. And it leads us to focus in those areas. And they're the wrong areas to focus on. So I think a really critical matter is who decides what gets measured. And here I can say that the people who have made the system that we currently work under are the same people who've been doing this for 30 years. So consumers and carers, for example, and indeed I would have suggested in many cases providers, are not really given an opportunity to influence how data is collected and what data is to be collected. And on that basis, I would say that nearly 30 years after we started, we are largely outcome blind. But what I want to say is, and just to finish, a bit like Leonard Cohen said, everybody knows. Everybody knows that we are outcome blind and that this system is not working. And yet nothing has changed. No action has ensued. Why is this the case? How have I failed? Thank you.
Thanks, Sebastian, for that rather sobering overview. For those of us who might have been around in over at least the majority of the last 30 years, that kind of issue, and I'm glad you highlighted the fact that the issues of accurate measurement at the system level, although I think increasingly at the personal level, have been challenging. And in mental health, and I don't think this is a uniquely Australian phenomena, we have struggled to move down that path. So it's not just an Australian phenomenon, it's been an international phenomena that in our area, reconciling the complexity of the areas we deal with the need to use measurement to drive quality improvement. And back to Danny's point, most principally for those who use those services to optimise their outcomes, plural, their outcomes across those areas, remains very challenging. We might leave it up to others to comment on the why for a while or come back to it in the discussion. I'd like to move along to one of our senior postdoctoral fellows, Frank Iafino, who's worked with us about longitudinal trajectories in young people. This is a classic for us. We have set up early intervention services in Australia, very proud of the fact that we're part of the Headspace sets of networks. But what really happens to young people who come into those services over time? What are the likely range in outcomes rather than the average outcome? And what are the longer term functional outcomes in particular? And particularly, Frank's also been associated with our attempts to use digital technologies to both improve not just the overall tracking, but the individual experience along the way. Frank, since you're younger, are we going to do a better young job over the next 30 years?
Hopefully, plenty of opportunities ahead, I think. And I'm happy to be here to present on measurement-based care in the context of youth mental health care, as Ian mentioned. So no surprise that trajectories of mental health are multidimensional and they're complex. There isn't simply one dimension or a single factor to be measured. So here I've just selected two dimensions by which we measure a person's illness. And on the left, each figure here shows the possible trajectories we've identified in our own work with young people presenting to services. So on the left is a social and occupational functioning where you can see highly dynamic trajectories whereby some people deteriorate immediately after presentation to care, while others do so more slowly, as well as some more stable trajectories whereby people present and remain persistently impaired, or others who are able to maintain relatively good functioning over time. And on the right is risk of illness progression from either mild to moderate or moderate to severe disorders, along with some of the key predictors we were able to measure, which gives us some indication about who may be at risk of progression. And so we are obviously interested in preventing or delaying some of these poor trajectories, yet doing so requires identifying and measuring the outcomes across multiple dimensions, in addition to other factors which may be driving outcomes. Next slide, please. Now, if we zoom in on each of the functional trajectories from the previous slide, as you can see on the right-hand side there, so that now each person is represented in the graph as a line. So you can see that while our modeling has clustered people based on those who follow similar patterns over time, there's still significant variability in and individual change over time. This major heterogeneity in possible trajectories means that predicting outcomes for any given individual is difficult. So in practice, determining when to adopt specific intervention strategies and for whom is very challenging. And as you can imagine, this is even more challenging when someone first presents for care, because you only have a single point estimate to go off, or this may be just one assessment point, which gives you very little information about which direction they're trending in. And so only with more rich and continuous measurement can you start to build a clearer picture about someone's trajectory. And hopefully along with that, you can gain some insights into what works and what doesn't work, and therefore the interventions which are most likely to be effective. Next slide, please. And so it's this systematic and continued assessment of an individual's outcomes to make decisions, which is measurement-based care in this context. And it is a core component of most chronic care models, where it is common for people to oscillate between health and illness over long periods of time. And this type of approach has demonstrated effectiveness for improving symptoms, reducing likelihood of deterioration, and enhances the accuracy of clinician judgments through objective assessments. It also, as you can see there, has a number of other benefits related to therapeutic relationships and collaboration among providers. But unfortunately, it's still not standard use in mental health care settings. And it faces many implementation barriers which seem to persist. So some of these may include the things like the lack of the right data and technology infrastructure, variation in professional views and formal training, or lack of the right incentives in health systems for its consistent use, as Sebastian touched on. Next slide, please. But one of the biggest enablers for measurement-based care is the integrated use of health information technologies. In this paper, we presented the concept for a digital platform which aims to facilitate measurement-based care within a mental health service. And here, this figure just shows the general trajectory or how it might be used in practice. And what it does is it assists the assessment, the feedback, the management and monitoring of mental health by collecting personal and health information from a young person and their clinician or other people involved in their lives. And prototypic work on this platform demonstrates its utility to enable appropriate and timely response for people reporting higher levels of suicidality. It facilitates more broad assessment of the totality of a young person's needs and enables clinicians to move away from traditional evaluations towards the ones that are more data-driven, detailed data-driven. And I think Lara will touch on a bit of this next. But importantly, when using technologies, it means that monitoring isn't just restricted to clinical contacts, so those X's in this figure here, but rather you can use technologies to set up more real-time assessments away from the clinic during active care periods. And so this is, as Sam mentioned in the video at the beginning, this is where connecting activity and mood trackers becomes really, has its most value. Next slide, please. But measurement-based care also gives us the opportunity to deal with the complexity of mental health. So the systems that give rise to psychopathology and trajectories most likely arise from complex dynamics between many social, psychological, and biological factors. Yet we often rely on mental models of these complex dynamics when trying to make decisions. So with the use of more sophisticated technology infrastructures, we can provide better inputs for measurement-based care, such as multidimensional assessment, neurobiological function through things like neuroimaging or neuropsychology, understanding more about genetics, as well as information about the interventions delivered over time. And I think this is what makes measurement-based care more than just outcome monitoring, but rather it's about collecting relevant information to make more informed decisions. And if we start to integrate this information with causal inference and modeling approaches, then we may be able to start uncovering the dependent structures between a given set of variables over time. And it's this type of inference which has the potential to identify most likely causal links between multiple variables over time and help us deal with the uncertainty regarding a person's risk, regarding what the drivers of illness may be, and potential effective interventions. And it also will help us identify what piece of information do I require next to help reduce that uncertainty or increase my confidence even further in an identified risk for a given person. And this really allows us to create a system whereby we are being guided by the best available knowledge about a person and constantly learning so that we can provide more targeted mental health care to improve a person's outcomes. And I'll leave it there.
Thanks, Frank. You've raised some really important issues. And one of the questions on the Q&A, I encourage people to continue to use the Q&A, was in reality, is every experiment actually N equals 1? Well, yes. You know, each episode of clinical care is an experiment over time. I think the importance about the trajectories you showed earlier, however, repeated measurement, particularly early in the course of clinical care, we may be able to work out trajectories. And the point you just made at the end, it's a learning system. The more of the data you collect over time is not itself rigid. It will be more informative about individuals in their own care. Systems can learn smarter things by having data available continuously and not going back to pre-existing mental models, as you've emphasised. So I think we are living in quite a different age in the way information can be handled in real time, and the complexity of information can be handled if it is collected. If it is collected at the personal level, and if it is collected at the system level at the time, we can have smart and learning systems. There are many things people of my age just don't know. There are things we don't know at the individual level and at the system level, but we can learn. Thanks, Frank. Now, the next speaker comes to us from across the globe that we can no longer travel in together. But Lara Ospina-Paninos is sitting in Colombia, in Bogota, at 3 a.m., just in case any of the rest of you are feeling a little tired at the end of the day, 3 a.m. And we had the pleasure of Lara actually completing her PhD with us in Sydney on technology and its innovations in providing care, and has now returned to Bogota. And if any of you think you're doing it in tough circumstances, by comparison in Australia, we are not. But Lara's taken those insights back, and she's taken the potential for technology for 45 million people, I think it is, in Colombia, facing huge challenges. The role of both technology and of measurement to improve the lives of people globally. So thank you, Lara, for the 3 a.m. kind of presentation. I'm sure you're wide awake and dying to hear what you've got to say.
Thank you so much for the invitation. I'm really happy to be here with you. Now it's almost 4 a.m. So this morning, I can say that. What I want to show you today is the actual potential of measurement-based care to improve us how to provide a better care in low and middle income countries. And this slide that we're going to spend a little bit talking about here is representing the challenges that people that lives in these parts of the world in low and middle income countries face. And I just want to draw your attention to the amount of people that actually live in these countries. So low and middle income countries host 80% of worldwide population and 90% of the youth, right? But the problem is that just 20% of the mental health resources are invested in our countries. And that brings us a big problem that it's this huge treatment gap. This treatment gap can be as high as 90% in some countries. That means that just 10 people who need help out of 100 will actually get the help that they need. So in that terms, in relation to the treatment gap, I want to highlight some points of how actually measurement-based care can help us to address this gap. So the first thing is that at a public level, if we do have, just stay there for a while. If we have better data, better, as Seb was just mentioning, if we could inform our policies, and these policies are driven by actual data, we will have better policies, and therefore we could have better user-centered models, right? And then the other thing is that we could, if we have better data, we have been measuring the population's outcomes, we could allocate the resources to the need. Say, for example, if we have an area which have, I don't know, high alcohol consumption levels, we could match those services and those requirements to the needs of the population. And that can be done only if we measure at a public level. And then the other thing that I'm really jealous is that actually since 1992, your mental health policy is talking about the need of measuring, right? So for example, our 2018 policy is not even talking about monitoring outcomes. It's just only talking about how we could implement the public mental health policy. So, so I think that if our policies are not very focused on monitoring these outcomes and making these outcomes that we are going to monitor the same as the other countries, we will never be able to compare the data and understand where are the areas that we could potentially improve. Then measurement-based care at the individual level, I think that could address the gap in two ways. The first way is that we know that since a person starts to have a problem, there is more or less a 10-year lapse between having these first symptoms and actually getting help. So I think that if we could, as Frank was just saying, if we could monitor systematically some of these outcomes and actually try to combine those complexities very early on, we could actually start to predict better who's going to need care, who's going to improve, who's going to get worse. And actually, if we start seeing early on that that person could have a potential pattern or whatever to need care, we could intervene early. And that's something that we need definitely to, because in low and middle income countries, we cannot afford people waiting 10 years to see someone. And that leads me to the second point, that it's the quality of care, of course. That's also part of the treatment gap. And as you might know, of course, and it's I think that it's an issue across the globe. Even if you get help, you don't know if your help that you're getting is actually evidence-based. And doing measurement-based care can help us to provide evidence-based care, to personalized care, and actually, as Sam was just saying, to involve the users in their own decisions, to empower them, and to actually make them what we really need them to be, that is an empowered user. And I think that that's something that measurement-based care can give us. So by measuring systematically, we are not going to provide a timely, efficient care, but also we can provide quality care. And that leads me to the other point, is that as you might know, in our countries, mental health is some of the policies are trying to enhance primary care, and therefore some clinicians or some community workers are not very familiarized with some of the mental health problems or early recognition of these problems. So if we measure systematically and we have these systems, as what Frank was just showing us, we can support clinicians, we can support primary care, and we can support less experienced clinicians to make better decisions and actually to match the care that actually people need to the specialist very early on. On the other side, I think other of the challenges that our countries face is not only the health inequities that we're talking about, is that we are also facing digital health inequities. And that's related that most of the people cannot have access to treatments or systems that could help them potentially, but that's also very linked to the monitoring systems across the country. So our surveillance systems are not very good. And of course, if we don't have strong surveillance systems, that means that we don't have the technology to actually monitor in an individual or in a public level. So that it's going to always, if we have the technology to monitor, that's always going to increase this digital health gap. And we are going to have, like, we're never going to make proper policies, data-driven policies. We're never going to provide at scale these user-centered models that we are talking about. So that only means that if our surveillance systems are not strong, if we don't have the technology to monitor in an individual basis or in a public health basis, the only thing that we're going to get is a wider gap in the treatment in these countries. So as you know, of course, and part of this series, Flip the Clinic, is the importance and the role of technology and how we could, through the digital health interventions, start to do this at an individual and a public level. But of course, in our countries, we cannot afford to do it wrong, right? So next slide, please. So that's the other point that I just wanted to share you, is that we have to make use of smart technologies that has already been improved in other parts of the world, and that's my job currently, of how we can take something, bring something that has been developed in Australia to Colombia. And it's not a simple solution of cut and paste. We need to do it properly because we need to adapt it to the culture, to the context, to other variables that are going to affect mental health. But the most important thing is that it can be done easily, rapidly, and that's the point that I just wanted to bring you. Personalized care is nothing without a cultural and a context appropriate care. So that's why we have to just do it through a rigorous methodology. And the other slides is just to quickly show you how we can do, next slide please, how we can, an early prototype, this is just an early prototype of a clinic that actually measures, next slide please. Next slide. Yes. Next slide, please. Yes, thank you. So something that we developed, no, the previous. Okay, something that we developed early that it's going to monitor, and then as a consequence can monitor in a regular basis, that's going to inform at the individual level, but also going to aggregate to public level, how we can translate it, adapt it, and then use it in a different setting, in a different language, and in a different context, being appropriate. Next slide, please. And next slide, please. And how we could, and that's part of the time efficiency and the quality, how we could detect cases that need to be addressed immediately in a more efficient way. And actually, this is even more ethical than making them to wait to see a professional for more than 10 years, or to make them go from one place to another just to see a specialist. Next slide, please. This is a quick example of how in a 45-minute consultation, we could improve the quality of that consultation, reduce the time of the assessment, make better decisions, and to jump to other kind of very important things that we have to in our consultation, such as provide tools or do other things that we need to, like psychoeducation or something, in a very short period of time. That's the efficiency bit. And next slide, please. And I just wanted to show you that we cannot do this alone. We need to learn from the experience, and this only can be done if we have strong partnerships and we collaborate across the globe, because just remember that mental health is a global need, and if we collaborate, like, we all can learn from each other and contribute to the biggest objective, that is the mental wealth of the population worldwide. Thank you so much. I will leave it there.
Gracias, Lara. And I'm not sure whether it's buenos dias or buenas noches, because it's really impossible to tell now. I mean, but what you've demonstrated so well is a willingness to use technology in difficult circumstances to do both, to get quality care, but also more efficient care at times. Just almost out of time to where we started. Sam Hickie at the start described being in a complex system of care that was looking at his physiology, his illness course, was empowering him. And of course, that system he was describing is run by the person sitting next to me, Professor Elizabeth Scott, and has been doing this with young people through the use-based system that she's been associated with, of trying to actually use neuropsychological assessment, greater physiological determination, greater use of technology for young people with more severe disorders as they come into care. So Liz, what do you make of it as a provider? And what about the young people you look after?
So thank you, and thank you, Lara. I feel almost embarrassed with the resources that we have, that we haven't made more progress, as Seb has said. So I work in a hospital system where I think that personalised care and precision medicine is talked about a lot, and it really refers to, complex genotyping. And my comments to the hospital system is there are many things that we can do better now. There are many things that we know how to do that will enhance patient care, promote better outcomes, and provide the feedback that we need to continuously improve the quality of what we do. So we have been trying to institute this in the inpatient service that I work in, and that includes more measurement-based assessment care, using actigraphy, tracking sleep and activity patterns in young people who are admitted to the unit, using neuropsychometric testing, using measures of, as Sam Hickie has said, of kind of immune, metabolic and hormonal systems to actually help to drive decision-making in care, so that we can improve the efficiency of our assessment process, and that means shorter admissions and improves the capacity to treat more people. We've also instituted ICBT into our treatment program. I think we talked about this on a previous webinar, which has the advantage of providing high quality standardized care to the young people within our unit, which then also allows us to track their progress over time and can be used to track their progress from one service to another. So not only can we look at outcomes within our unit, we can then look at the outcomes as those young people leave our service and move to other services, with knowing that they've actually had a standardized kind of treatment intervention. So I think all of those things have taken a long time to institute, longer than they should. They have been extremely rewarding. They've involved a lot of education of clinicians. They've allowed us to skill our workforce, particularly our nursing workforce, to provide them with the skills to be able to provide this more enhanced assessment, which is really important in terms of the workforce shortages that we have in psychiatry in this country and across the world.
So Liz, you just alluded to one of the other issues though, is you're trying to do what you're doing in your service. Yes. And then you've got people moving between your service who've been before and may have been hospitalised, moving on to other services. What is actually the willingness of our different service systems to share that same information journey across different areas?
There is no, whether there's a willingness, there is no platform, there is no shared data system that allows us to do that in a meaningful way. Most of the EMRs are driven towards, data collection, occasions of service. They're for the system, they're not for the person. So there is a real need, and we hope that we will be able to put a platform in place that mirrors some of the work that Frank has discussed and that Lara has been involved in terms of her PhD, that is a digital platform that allows us to do these complex assessments online in time-efficient ways that enhance clinical judgment and that allow us to track people not only for our service, but across other services.
So maybe mental health will get to find out what this is, a digital platform that people carry in their pockets every day of the week. I give the small example. I was thrown out of a Kevin Rudd 2008 2020 forum by suggesting in mental health the technology already existed in 2008 for people to track themselves across services, what services would never do, but the person themselves who cared might actually move across those services. The book I showed at the start about healthcare reform now is actually driven by the idea that since when in healthcare did we not understand it was the person themselves that was the most interested in the outcome of that particular set of issues? And that as they moved across, they didn't care what happened to everybody else. They care what happened to them. They were not an average. They were not the outcome of an average of a clinical trial. They weren't what happened on average. They wanted to know whether the care decisions that were happening to them were based on them and their particular issues. And was that information carried forward with them as it led to either good experiences, bad experiences, side effects, whatever? And were the outcomes that were being tracked those that were most relevant to them? In many people's situations, certainly in mental health and on discussion right at the moment, participation, the return to actually being functional at school, at work, in the societies in which we live. Now, I'm very thrilled to see that the majority of people who actually started with us an hour ago are still here on a questioning basis. And we've tried to respond to a number of questions along the way. And those we haven't and typed answers to, we'll try to look at. But I would just like to ask the other panelists before we actually wrap up, are there other issues that have arisen that they think require some further comment at this stage?
Can I say something, Ian? Just again, I mean, given that I'm sort of looking at it from a system point of view, I just wanted to say that I think one of the critical areas here that this kind of personalised measurement-based care can really lead to, leaving aside the interaction and demonstration of progress or otherwise between a person and their service, leaving that aside, and that's perhaps the main thing. But I think if you look back at 1992, mental health got about 7% of their health budget. It still gets about 7% of the health budget. My point is really just to say that this kind of evidence can not only play a role at an individual level, it can actually show the merit of spending on mental health care for national outcomes. And I think this is a really valuable element of thinking and a resource that we should be looking at to try to show the merit of the spend and that it's worthwhile doing, rather than people with mental illness somehow being a lost cause. I think that this is actually part of the reason which still informs stigma, which is that somehow it's not a valuable spend of effort or resources. And I think this kind of approach to measurement can really lead us away from that and to a much brighter future. Thanks.
Look, I think it's a key point you're driving at there, Seb, and I point out all the time. I'm the son of a cardiologist, and they've always counted things, particularly men my age, alive or dead, and they've been able to show continuously over the last 30 years, actually, each time they improve the system, what they do next to improve the system at the individual level and then at the population level to justify further investment. So now, despite the remarkable improvement in outcomes for men of my age of cardiovascular disease, we're investing more in that area. And similarly in cancer at various areas where that continuous feedback, and I do think there's an ongoing issue that we are challenged about, do our services actually result in that continuous improvement in people's lives that is so characteristic of other health areas in which we invest as a nation? I think it goes back to Danny's point. We get involved in a lot of debate about whether it's good or bad or ugly. A lot of it is indeterminate. We just can't really make the argument. And perhaps that partly explains why we get stuck at the 7% of funding and we make the struggle. Danny, do you have a view about that? Because you raised the issue about Seb and I are perhaps, despite being born optimists, are sometimes a bit negative as distinct from we just don't know.
I'm a kind of an optimistic pessimist, but I think you're right. I think there are lots of people doing really very interesting work in the system, and I could show slides of perhaps one of the best psychiatric rehabilitation programs in the world that I've seen in Western Australia, which are committed psychiatrists using measurement-based care tied to pathways, tying it to costs and doing all that. Elizabeth said, we don't have a system or a platform to share this information, to pull it back in so that we move from having like what I would call, and it's not pejorative, enthusiastic amateurs doing really good projects to getting us all into the game saying, and the reason why I put the National Planning Framework in, and I think it's an important thing, I was linking it, I've often referred to it as Windows version 1.0. And we have to kind of think about these systems like that. They're in an early stage. I think these sort of structures are fabulous to use, but we need to build the developmental architecture around it to get the developers to develop and create the structures in which they will show their kind of expertise and enterprise and build the system we want. Because it's not through lack of expertise and knowledge about what needs to be done. We just haven't got the system architecture to bring that to the fore. And it's astonishing to me that we can do it in other areas. The comment about cancer and heart conditions is, it's interesting how they managed to construct a proxy measure that approximates everything. So in cancer, they'll talk about the 5-year survival, and they have a staging model. It has abstract. It's an abstract notion, but it's a strong tool. It's not the only tool. It's a strong tool, and we need more.
But they're good enough tools. They're good enough tools, Danny. I think that's good enough, and continuous improvement. I think what we do think, and if there's I hate to think that anyone was terribly pessimistic here, but I mean the capacity to collect real-time information from people across chaotic systems has been solved for us in many ways by telecommunications that was not available in the early 1990s in the way it is now. And even in countries, Lara, you may want to comment, even what I was impressed with last time we were in Colombia, and we're very sad we're not there now, is actually, people may not know this, the extent to which Colombia is invested in a really functional national broadband network, and they are determined to use technology for education of young people and for health. The question, I think, is, you can see the investments the developing countries want to make, but are our clinical systems, Lara, going to actually cooperate with that? Are we going to be happy to work with that? Do you want to just comment in your own setting or in a different setting?
Yeah, well, I think that of course, the advance that we have done in terms of infrastructure, internet in Colombia, it's a driver to actually implement digital healthcare, and as well this kind of monitoring, this is smart monitoring, because as Ian was just saying, sometimes we don't know that the phone is monitoring things that we even know. I think that in say my experience, the users are very, very keen to start using this kind of technologies, all ages. We initially think that it was just for young people, but actually all people that have a smartphone. And I must say that in Colombia, one of the goods that people want to buy is the smartphone, as well as migrant populations. We right now have around 7 million migrants in Colombia, and for them the first good is like the priority is water, food, and smartphone. So I think that it's a way that we can connect, and the real challenge is how we can make clinicians and make services in love of these technologies. And the way that we can do this is by actually one, getting the advocacy of the users, and then the other thing is by showing this kind of data and how we can make this efficient and better quality and satisfaction as well of the users.
Okay, as we've gone well over our advertised 1 hour, I'd like to thank all of the participants this evening. I'd like to thank those who've come along, those who've particularly been very active on the Q&A, as there have been several. There are, of course, the other sets of agencies and a lot of the factors that we've advertised a number of times here that are worth discussing. I'd like to thank you for your time. These particular webinars that we run are supported by our host institution, University of Sydney, but they would not be possible without the generous support of the Bupa Health Foundation for our Circles of Care and Technology projects, Future Generation Global, which is a set of investment bankers who'd like to see much better mental health for children and young people in Australia through innovation in healthcare. Wonder whether sometimes those are the people who should be running the country. Just imagine that. They want to invest for innovation in child and youth mental health. So the mental wealth of our country, and as Lara's pointed out, internationally, may be enhanced by our efforts. Thanks for your attention, and we look forward to seeing you again in our next Flip the Clinic series.